Hi, everyone. Welcome back to the 2025-2026 Oncology Pharmacy Resident Clinical Pearl Series. Today, I'll be doing a rerun of my Grand Rounds presentation that covers the clinical management of immunotherapy-related adverse events. This is an increasingly critical topic as immunotherapies continue to see increased use driven by emerging clinical trial data and the evolving nature of cancer cell progression. Before I begin my presentation, I'll first disclose that I have no financial relationships or any conflict of interest to disclose in relation to the topic of this presentation. For the objectives of the presentation, I will begin with a review of immune system function, how cancer cells evade immune detection, and the mechanism of action for immunotherapies. Then outline the various classes of immunotherapy currently in use. Finally, there will be an explanation of how immunotherapy-related adverse events are managed according to NCCN guideline recommendations and other literature. Shown on this slide are abbreviations that will be used throughout this presentation. To begin with an overview of the immune system, our immune system plays a critical role in protecting and maintaining our well-being by identifying and destroying foreign cells in our body, whether they be bacteria, fungi, viruses, parasites, and of course, cancer cells. Innate immunity is our first line of defense in which our white blood cells surround and engulf these foreign cells. This acts pretty quickly and activates our adaptive immune response from B cells that create antibodies to develop memory of these foreign cells so that our immune system can quickly destroy them if they were to reappear in our body. Despite immune surveillance, cancer cells employ several mechanisms to evade detection. One way that cancer cells can escape detection is by losing or changing specific antigens that could be targeted by antibodies. They can also upregulate immune checkpoint molecules such as PD-L1, which effectively turn off T cells and prevent an effective immune response. This explains how cancer cells can transition through the equilibrium and escape phases, where the immune system is no longer able to suppress proliferation. Shown on this slide are the three phases of how cancer cells can evade immune surveillance. In the elimination phase, this is where the immune system is still functioning as intended and able to eliminate cancer cells from spreading to other tissues and organs. In the equilibrium phase, this is where the production of new cancer cell variants that are able to grow without being attacked by the immune system starts to balance out the rate of elimination of cancer cells that are still able to be detected and eliminated by the immune system. However, this gets to a point where the new cancer cell variants start to outpace the capability of the immune system to stop them from spreading to tissues and organs, and then this leads to poor health outcomes. Shown on this slide is a visual of the three phases of cancer immunoediting that I previously described on the last slide. This shows the consequence of what can occur when cancer is not treated within a timely manner. There are, of course, caveats to this where, depending on the staging and severity of cancer, you may not necessarily need to treat a patient with systemic therapy or oral oncolytics, but generally speaking, it is important to treat a patient with recommended therapies in a timely manner to prevent cancer from proliferating to tissues and organs because our immune system can only do so much on its own. Due to the fact that cancer cells have multiple mechanisms to evade the immune system, immunotherapies play an increasingly important role in treating various types of cancer. With immunotherapies, this is a broad term for treatments that leverages the immune system to target cancer cells. Monoclonal antibodies are synthetic proteins that are designed to mimic human antibodies. They encompass most types of immunotherapies except for adoptive cellular therapies. For the purpose of this presentation, I will specifically focus on immune checkpoint inhibitors and bispecific T-cell engagers, as these are the most frequently utilized immunotherapies at our institution. Immune checkpoint inhibitors are by far the most common immunotherapies used for treating cancer. There are three classes of immune checkpoint inhibitors, and the way that they work is by binding to ligands of immune checkpoint molecules to prevent T cells and other immune effector cells by being downregulated. Examples of CTLA-4 inhibitors are ipilimumab and tremelimumab. These immune checkpoint inhibitors are used for treating melanoma and hepatocellular carcinoma, respectively. With relatlimab, this is used in combination with nivolumab to treat metastatic melanoma, while for PD-1, PD-L1 inhibitors, some examples of these are pembrolizumab and nivolumab, and some cancers that they treat are breast cancer, colon cancer, and other solid tumors. Shown on this slide is the PD-L1 interaction of how PD-L1 or PD-1 inhibitors destroy tumor cells. While this does not show other immune checkpoint inhibitor mechanisms, the essential concept of how this works is applicable to all immune checkpoint inhibitor molecules. Shown on the left-hand side is what would occur when these immune checkpoint inhibitors are not used, where the tumor cell uses its ligand to bind to a target on the T cell to effectively turn off the T cell from detecting and destroying it. But when an immune checkpoint inhibitor is used, this is where this negative interaction is prevented from occurring, which essentially is like turning the light on for the T cell to then detect the tumor cell and then destroy it. As with the use of any medication, there are adverse events to be mindful of. Specifically, with immune checkpoint inhibitors, there is a high incidence of immune-mediated adverse events of varying severity. Interestingly, research suggests that these events may be more prevalent than the primary literature indicates. Researchers at Washington University in St. Louis and Tisch Cancer Institute in New York analyzed 75 primary articles from clinical trials that led to FDA approvals of these agents. Their findings suggest a significant trend of underreporting for many toxicities, most notably myocarditis and aseptic meningitis. With immune-mediated adverse events, they can affect all organs in the human body as the immune system sends T cells and other immune effector cells to eliminate foreign cells. But there are organ systems shown on this slide that are more commonly affected than others. With different classes of immune checkpoint inhibitors, studies have found that they can affect different organ systems more than others. The reasoning for why this is not quite clear, but this is what has been shown in studies for what they more commonly affect. While the incidence of different organ toxicities will vary based on the class of immune checkpoint inhibitor utilized, beyond incidence, we must also consider the temporal patterns of these events, as the onset will vary depending on the organ system affected. As illustrated on this graph, dermatologic toxicities typically manifest early, often 4 to 6 weeks from the start of immune checkpoint inhibitor treatment. Conversely, pulmonary toxicities tend to be more delayed and can occur 10 weeks or later from the start of immune checkpoint inhibitor treatment. Understanding these common windows of onset allows us to maintain a higher index of clinical suspicion at the appropriate times during a patient's treatment course. Because we are familiar with the common toxicities, such as rashes or pneumonitis, I have narrowed the focus of this presentation to be on the management of less common, irreversible, and life-threatening adverse events because they require rapid identification and aggressive intervention to prevent permanent organ damage or mortality. For comprehensive management of all our toxicities, I highly recommend utilizing the NCCN guidelines for the management of immunotherapy-related toxicities. A free account provides access to these frequently updated treatment guidelines, which cover both common and rare supportive care measures. Shown on this slide are the different grading or categories for determining how severe these immunotherapy-related adverse events are. With grade 1 events, these are the least severe. adverse events in which only observation is needed, while for grade 3 and 4 adverse events, this is where more urgent and aggressive intervention is needed, and a patient will need to be hospitalized for further care. To show an example of how this grading system is used for the management of an immunotherapy-related adverse event, with the management of ICI-induced colitis for grade 1, the recommendation is to hold immunotherapy, utilize supportive care measures such as hydration and dietary modification, and then you could consider other medications for symptomatic relief, and then check biomarkers to see if further escalation of treatment is needed. When the colitis is more severe, this is when immunotherapy is held or discontinued, and then more steroids are used to treat the immune-related adverse event to counteract the immunotherapy from causing more potential damage. Because at this point, this is where the risk of immune-related adverse events outweighs the benefit of cancer treatment. Additional agents may also be used to further treat this adverse event, which in this case, this is where infliximab or vedolizumab is used for ulcerization or microscopic colitis. This slide shows the incidence of endocrine toxicities after the use of immune checkpoint inhibitors. These instances are reported from a meta-analysis of 38 randomized controlled trials that were evaluated by researchers at the Dana-Farber Cancer Institute and Brigham and Women's Hospital in Boston, Massachusetts. While the incidence of these toxicities are rare, it is important for me to cover the management of these toxicities because they are irreversible and potentially life-threatening if not treated appropriately. For the management of primary adrenal insufficiency, these recommendations come from ASCO and ESMO guideline recommendations and expert opinions from endocrinologists in France. The NCCN guideline does not have specific recommendations on how to manage this other than a statement from them that says that it's a rare diagnosis that is not usually associated with checkpoint immunotherapy, and that if there is concern for it being caused by immunotherapy, to then consult endocrinology. Based on what we do know from the current literature for how to manage this, the recommendation is to hold immunotherapy until the patient is clinically stable for any severity. And it is also recommended for patients to wear a medical alert bracelet and have an emergency kit with hydrocortisone injection due to the fact that the patient now has irreversible loss of adrenal function. Depending on the severity of primary adrenal insufficiency in the patient will receive varying doses of hydrocortisone in divided doses as well. Type 1 diabetes can be caused by immune checkpoint inhibitors from the destruction of insulin-producing beta cells by autoantibodies. This is why C-peptide levels should be assessed in this patient population, because low or undetectable levels would indicate deficient beta cell function and can help with diagnostic workups of what could be causing this condition when a patient presents to the emergency department or an inpatient floor. This condition requires insulin replacement as directed by an endocrinologist, regardless of if DKA is present or not, and close glucose monitoring is needed to ensure the best care. If the patient does have DKA, this is where immunotherapy needs to be held until resolution, while if DKA is not present, this is where immunotherapy can still be continued according to NCCN guideline recommendations. With myasthenia gravis, this is a neurologic toxicity that can be caused by the use of immune checkpoint inhibitors due to the increased production of autoantibodies that block neuromuscular signals. The onset of this is delayed and typically occurs from 3 to 4 months after treatment initiation. Patients who have myasthenia gravis will typically present with drooped eyelids, trouble swallowing, and in more severe cases, respiratory failure. Based on the NCCN guideline recommendations and other literature, they recommend to consult neurology, discontinue immunotherapy, and avoid any medications that would exacerbate myasthenia gravis. It's also recommended to treat the patient in an inpatient setting where they can be more extensively monitored, and also give the patient steroids as well as pyridostigmine to directly counteract these autoantibodies that are blocking these neuromuscular signals. In more severe myasthenia gravis, this is where the patient will receive higher dose steroids, frequent pulmonary function assessment, and daily neurologic evaluation. IVIG and plasmapheresis are also given along with steroids, but if these treatments do not work, this is where rituximab can be added on. For the last immune checkpoint inhibitor toxicity, I will cover the management of myocarditis. This is a rare but important toxicity to be aware of because this can be very life-threatening if the patient is not treated appropriately. It is recommended by NCCN to discontinue immunotherapy if this does occur in any capacity, consult cardiology and monitor the patient in ICU level setting. Additional cardiac workups with cardiac catheterization and myocardial biopsies can also be done if clinically indicated. It is also recommended for the patient to receive IV methylprednisolone 1 gram a day for 3 to 5 days. But if the patient does not respond within 24 to 48 hours on these steroids, it is recommended to start additional immunosuppressive agents like abatacept or mycophenolate to counteract these antibodies that are attacking the myocardial tissue in the heart. As you have seen from the management of various immune checkpoint inhibitor toxicities, corticosteroids are commonly used for more severe adverse events. Despite this, there are drawbacks to overusing these corticosteroids. And this is highlighted by this multi-center global cohort study that was released this year that examined around 400 adult patients in 8 countries with stage 4 non-small cell lung cancer who were treated with immune checkpoint inhibitor therapies. The study found that there was a statistically significant difference in median overall survival and median cancer-specific survival, in which patients who received higher doses of steroids had lower overall survival and cancer-specific survival. They also found a numerically lower median progression-free survival in the group that received greater than 100 milligram prednisone equivalent doses, but this was found to not be statistically significant. Shown on this slide are the graphs of efficacy outcomes that were impacted by higher corticosteroid doses in patients who were treated with immune checkpoint inhibitors for metastatic non-small cell lung cancer in the global multi-cohort study. These results are not surprising because with higher corticosteroid doses leads to higher immunosuppressive effects that impairs the capability of immune checkpoint inhibitors to enhance the capability of T cells and the overall immune response to destroy cancer cells. This also highlights the importance of benefit risk assessment, in which corticosteroids should only be reserved for the treatment of more severe immune mediated adverse events, as outlined in the NCCN guide recommendations, so that the benefit of treating cancer is not compromised by the use of corticosteroids unless the risk of these toxicities are determined to be much more life-threatening to the patient. Now, to switch gears to a much more active form of immunotherapies, I will discuss what bispecific T cell engagers are and ways to manage toxicities that are associated with bispecific T cell engagers. Bispecific T cell engagers work by binding to a target on a tumor cell and a target on a T cell to directly bring them together to destroy the cancer cell. The cancer cell is destroyed from this process from the activation of T cells and the release of inflammatory cytokines that directly burst the cancer cell. Because of the inflammatory cytokines that are released from this mechanism, CRS and ICANS are toxicities that can occur with BiTE therapy. And this is also why CRS and ICANS are listed as black box warnings for most BiTEs, where the incidence of CRS can be as high as 90%, while ICANS is not as common, where it can range from 1 to 9% incidence. Because of these toxicities, step-up dosing is done to lower the risk of patients experiencing severe CRS and other adverse events. Premedications are also typically given before administering BiTE therapy, where patients will receive corticosteroids, acetaminophen, and diphenhydramine. Hospitalization for at least 24 to 40 hours is also recommended for first treatment, just to ensure that if a patient were to experience a severe CRS or ICANS event, that they can be treated immediately. Patients who do experience CRS will all have a fever of at least 30 degrees Celsius. They may also experience mild symptoms such as headache, rash, muscle pain, and joint pain that are nonspecific. For more severe symptoms to look out for, low blood pressure, in which they have systolic blood pressure less than 90, and acute respiratory distress syndrome are other parameters to look out for when CRS is much more severe. The onset of when CRS can occur can be as early as within a few hours of administration or days after BiTE is given to the patient. As mentioned previously, fever is a hallmark symptom of CRS, in which patients who have it will have a temperature of at least 30 degrees Celsius, no matter what the severity is. The differentiating parameters of how severe CRS is dependent on the degree of hypotension and hypoxia that require additional vasopressor or submental oxygen or intubating support. For the general management of CRS from bispecific T cell engager therapy, an assessment of infections and inpatient monitoring will be done regardless of severity. For less severe CRS, the offending drug will be held and restarted only when symptoms are resolved prior to the next scheduled dose. There are exceptions to this where blinatumomab can still be continued regardless of grade 1 or 2 CRS occurring. Fluids and steroids are given to treat less severe CRS, but if the patient were to not respond to steroids within a 24 to 48 hour period, this is where IV tocilizumab can be considered, where one dose of it would be given at an 8 milligram per kilogram dosing. If the patient then has more severe CRS that requires vasopressor and or submental oxygen support, this is where intensive monitoring in an ICU level setting is recommended. Higher doses of steroids will also be given, and tocilizumab will typically be given more frequently if they are not responding, in which 3 doses can be given in 24 hours for a maximum of 4 doses total for a max dose of 800 milligrams. With ICANS, the onset is delayed and can occur 2 to 8 days after the onset of CRS. Patients that have ICANS will typically present with neurologic symptoms such as confusion, headache, attention deficits, and in more severe cases, comas and seizures. Patients who are more at risk for ICANS typically have higher tumor burden and pre-existing neurologic condition. The severity of ICANS is determined based on a patient's response to tactile stimuli and whether or not they have higher intracranial pressures and or presence of seizures. Nursing can assess the severity of ICANS based on the patient's capability to follow basic commands. This is something that nursing at Monument Health already do to some degree to assess patients' cognitive ability, but shown on this slide is a more specific assessment of how nursing can determine whether or not a patient has severe ICANS based on their capability to know the year, month, city, and hospital that they are in, their ability to name 3 objects, and also whether or not their handwriting starts to deteriorate if they were to experience ICANS. The general management of ICANS is pretty similar to CRS, in which steroids are given for the occurrence of ICANS. The only caveats is that levetiracetam is given for seizure prophylaxis, and tocilizumab is really only given if CRS is occurring concurrently due to the fact that tocilizumab has poor blood-brain barrier penetration. In rare cases, HLH could occur in which a life-threatening immune response that involves pro-inflammatory cytokines and hemophagocytosis can lead to end organ damage. This is commonly seen in patients that have severe CRS and high disease burden. HLH has a delayed onset of action and typically occurs as CRS is resolved or in the process of resolving. Clinicians can use this 2024 diagnostic criteria to quickly determine if a patient has a high probability of HLH that needs to be treated. This diagnostic criteria was updated from the 2004 criteria to get rid of impractical markers such as the assessment of natural killer cell activity because many medical centers cannot perform this specialized functional assay for determining the natural killer cell activity. And the result is typically not as accurate as modern cellular assays, and this could lead to diagnostic delays in a life-threatening condition that needs to be treated as soon as possible. This diagnostic criteria is also more applicable to adult patients with HLH because the 2004 criteria was originally developed for pediatric patients with genetic HLH. There's a model available on MDCalc that has all these features that can determine the probability of a patient having HLH based on these parameters. For the management of HLH, anakinra, which is an interleukin-1 receptor antagonist, can be given with or without steroids for the initial treatment of HLH. But if a patient is still not responding to anakinra with or without corticosteroids, this is where ruxolitinib can be considered. If the patient still does not respond to ruxolitinib, this is where other alternative agents, such as etoposide, which we have given to a patient at Monument for HLH, can be considered. And apalutamab is another treatment option that can also potentially be considered for subsequent therapy of HLH. Ultimately, what I hope that you all can take away from this presentation is that immunotherapy-related adverse events can affect multiple organ systems, and the treatment of these side effects may differ based on severity. The onset of action for these adverse events can also be delayed by several weeks to months, and this is important to consider when working up a patient that is presenting to the emergency department or other inpatient floors with potential toxicities that could be caused by their immune checkpoint inhibitor therapies. Steroids are also recommended for treatment of most immunotherapy-related adverse events, and the decision on whether or not to hold immunotherapy would depend on the severity of the events that are occurring. Lastly, it's also important to consider consulting other specialties depending on the organ systems that are affected by these treatments. Shown on this slide are the references that I used to create this presentation. Thank you all for taking the time to listen to my presentation today. If you have any questions or feedback on the contents of this presentation, feel free to reach out to me at cchen1@monument.health. Thank you.